Good morning. My name is Dr. Alan Stewart here at Mount Sinai Hospital. Welcome to structuralheartlivecases.org. Today we are pleased to join Dr. Samin Sharma for a transcatheter aortic valve replacement. Welcome, Dr. Sharma.
All right, well, with our team here, welcome for our third series in a row, and everybody should be there. And Ani, our the surgeon, Dr. Ani Anwani, just joining with Dr. Keeney on my right side and Jason Kovacic, and we actually now have a structural heart disease fellow as of January, which is Von Terre. So with that note, the whole these cases are basically go through the techniques and try to show and duplicate the results, the excellent results which we are having at Mount Sinai. Just we are done for coronaries and of course now for some endovascular. So purpose will be to go through the step by step what is being done in these TAVR cases. Of course, it's a multidisciplinary team approach, and everybody will be involved, and you'll hear discussion by everyone. So with that note, I think we start. This is the case. We go to our slides, and we'll ask our viewers to just put in questions so that will be timely answered. These are our sponsors. Next, these are our disclosures. And now Anu will take you through this case presentation. Anu?
Yeah, if you see this, live case number 3, 73-year-old female. Her presentation was way back when she came to us in 2013, when she presented with progressive exertional dyspnea fatigue with the NYHA class 3. At that time, she was found to be in heart failure due to aortic stenosis. So past medical history was hypertension, diabetes, and she was on dialysis. And the most important thing was that she was super obese with a BMI of 50. Medication, as you see, was listed, and echo did confirm the clinical finding that she had severe aortic stenosis with a gradient close to 50 and valve area of 0.6. So right-left heart cath was done. At that time we showed that she had normal coronaries with mild LV dysfunction, mild pulmonary hypertension, and severe AS. Even at that time, she was considered because of comorbidity, most important because of her obesity, that she was high-risk surgical candidate. We proceeded with the BAV and was discharged and was followed by her primary cardiologist on medical therapy for her heart failure, which actually she did change her lifestyle and kept losing weight. Next slide. So she was being followed, thinking that she may continue to lose weight and may become a surgical candidate. But she did. She's right now BMI of about 44. Then was being now evaluated for TAVR, and this is where we see that she had CT scan. She's considered high risk for surgical because her STS risk score is about 14.4, but most important is the EuroScore mortality about 28.1, and was determined extreme risk for surgical AVR because of her dialysis, need for dialysis, obesity, and restricted mobility, and her lung disease. We can show the echo findings now.
Yeah, but just come back to this point. I think this is an important issue, knowing that both whether we classify these patients as extreme or high risk. Ani did the surgical assessment. So Ani now with BMI has gone down from 50 to 44. You did an evaluation before. She does have some moderate restrictive lung disease. Should be extreme?
I think at a BMI of 44 on dialysis with marginal lung function, she's still an extreme risk. I think the chances are she'll be dependent on a ventilator after, so we wouldn't operate on this patient.
Perfect. So those are the cases now belonging to the in the cath lab or hybrid OR getting a TAVR procedure. Okay, next slide.
This is what the Transthoracic Echo had shown, that right now her mean gradient is 42, EF 60. She still continues to have severe AS. Next slide. And this is what was confirmed on echo. Where is Partho? If you can just explain what you saw on the echocardiogram, that she had what is called as a unicuspid valve rather than the tricuspid, which you see on the left upper corner, which is tricuspid valve. And then you see what they call is the tri-leaflet and the Mercedes-Benz sign, which you normally see, which we were supposed to see that in the CT scan, which we never saw. But Partho, if you can explain what this unicuspid valve is?
So maybe you want to show the echo also first,
Yes,
the live echo, and then tell us. Yeah. Good.
Yes, perfect. So what you're seeing right now are the images from transesophageal echocardiogram. This is the short axis of the aortic valve, and on the short axis on the right side is the color, and on the left side is the plain two-dimensional image. And if you see my pointer, you can see that there is only one slit-like commissure here. So this is a unique commissural valve, and so this one is a right coronary cusp, this is a left coronary cusp, and that's the non-coronary cusp. There are no commissures seen. So this is a complete fusion of the commissures, the other two commissures. The only commissure that is seen is between the right and the left coronary cusps. So this is a unique commissural, unique cuspid aortic valve. And if I show you the second image, what you will see here is a three-dimensional echocardiogram performed, which is confirming the slit-like apertures. This is a unique commissural valve, and we have performed a three-dimensional overview reconstruction. And on reconstruction, here we have obtained circumference, a perimeter of 7.2, an area of 4.1, and two diameters of 2.6 and 2. And you will see how closely this is corresponding to the CT scan measurements. Further, there is no dilatation of the aortic root. This is extremely important because in unicuspid and bicuspid, you need to make sure that there is no aortopathy. So there is no evidence of aortopathy. And on color flow, you can see that patient has, besides the severe aortic stenosis, also mild to moderate aortic regurgitation. And there is preservation of left ventricular systolic performance with an ejection fraction of 60%. The right ventricle is normal, and there is only mild mitral regurgitation.
Partho and Dr. Sharma, does this impact when you're placing the valve on how far into the LVOT you'll start your implantation when you have a unicuspid valve or a bicuspid valve, or will you proceed in the same manner as if it was a tri-leaflet?
Yeah, that's I think an important point which I wanted to ask Partho. Now that we saw that it was unicuspid, Partho, I think this is the first case that we definitely are doing, and I don't know if there have been any other cases. What do you think we foresee? I know we have done a BAV in the past, but what do you think we should be prepared for when we are now seeing that is a unique commissure, right? It's a single commissure, and the rest of the area is just a valve.
Yes. So I think the biggest question is how will the valve expand symmetrically? So the questions are how best we can dilate this up front. So whether we should be using what should be the size of the balloon. So we thought about 22 or a 23, and I will leave it up to the catheter team to come up with a decision. But basically a generous dilatation so that we can break the calcium and try to open up the valve as much as possible. And then with regards to the CoreValve deployment strategies, I'm not sure if I know of any specific way to implant it, but maybe a slightly deeper implant may be useful. But this is again Dr. Sharma and Dr. Kini are going to make the decisions.
No, once he showed it to us, normally we would have pre-dilated with a 22 balloon, but now that since he's telling that it's a unique commissure, and we have to make sure that that particular commissure is completely opened, or we actually have to split open the rest of the C-shaped area which does not have a commissure, we decided we will go with a larger balloon, which is a 23 millimeter balloon, and be very generous when we are doing the BAV. And definitely going back to Alan's question is where are we going to place the valve? I think in this particular case, we definitely will have to go slightly lower than what we normally would want to do, since there is a single commissure. And we have to, once it is split, we want to make sure the valve just stays there. If we are at a normal place, it may just push the valve higher up. That's what we predict. So we will go for a lower valve implantation. Okay. JK, now if you can discuss the CT scan.
Slide.
Show us the next slide, please. So just for the CT planning of this case, was a challenging CT because of the lady's obesity. The images are not great. Just show the first slide. So this is the annulus. You can see it's very fuzzy and hazy, and the perimeter mark we've got there is sort of excluding a small part that's opacified. But after a lot of backwards and forwards in different frames and different datings, it appears that the CT came very close to the echo. We got about 20 by 26 with a mean of 23.3, perimeter of 75, which puts it into the 29mm core valve. And with all the other considerations, we're going to stick with that implant size today. So to next slide, please. These are some of the other technical details. The ascending aorta diameter 27, the annular angle 37 degrees. So it's a fairly vertical angle, and that's very favourable for implantation. Next slide, please. So to show you then the sinuses of Valsalva, 29mm. A lot of calcium you'll see there at the sinus of Valsalva and at the leaflet level. But the CT was very difficult, and this was always planned as a transesophageal echo guided CT because of the challenges of interpretation of the CT scan. And you can see obviously what we've verified today with the echo guidance. Sinotubular junction height was fine, it was 18.5mm. And next slide. This is just showing the core annular sizing, and you can see by all measures this patient fits the 29mm. So that annular diameter mean was 23.3, ascending aorta 29, sinus of Valsalva 29, sinotubular junction height was 18.5, and the perimeter was 74, 75. So we're clearly within the 29mm core valve range by these
Next
measurements.
slide.
Next.
We have that. Yeah.
There you go. Those are all the measurements. Good. And next slide. So this is just to give you some sense of the size of the patient. BMI was still 45. The vessels there you can barely make out in the midst of the pelvis there, but the vessel diameters were adequate, about 8mm left and right. Next slide. So this is a summary of the case. As we've heard, 74-year-old lady, significant obesity, extreme risk, 29 core valve with a very complicated valve morphology.
Okay, so that we are all set and ready. If we show the aortogram, now question is that we did not see that unicuspid even on the CT. Now maybe just because of the patient's body habitus, as you JK showed, very fuzzy aortic valve appearance. So we go to puncture here, same. It's percutaneous.
Do you want to talk through?
It's the which kind of sheath?
Just to show you quickly the axis, we went with a micro axis here in the left side. The left hadn't been touched before. There'd been some cath through the right, so we chose the left because it was less scarred. Got nice axis with a micro catheter. Some shots of the root will come to, and then here we are gently advancing. This was a gore sheath in the end because there's a lot of soft tissue to get through. We needed a very stiff sheath to get through all the soft tissue, and the gore sheath went very smoothly in the end.
Okay. So now then we have the good the aortogram. See if we have anything which we can pick up on the aortogram different than before. I mean, to me, if you had to ask, I probably will say it's maybe a bicuspid valve, but it looks like usually bicuspid have very eccentric the sinuses, but we don't. So it's angiographically, there's nothing unique which I would point out that will make us to believe of this unicuspid on an angiogram. So we have crossed it, the valve now, with our AR2. That's our usual policy, using our AR2 and the straight tip Terumo stiff shaft wire. And now we are changing it to the super stiff with implants, making the wire, because guide wire is very, very important to really make it curve, so that, as we know, many of the injuries of the LV perforations and occur because of the wire. Now, very nicely, and of course, our partho will tell us whether the wire is in the good position, has gone through the any papillary muscles, and so.
It's a very good position. It's curved very nicely around the apex.
Good. Okay, now we have the 23mm ZMAT balloon.
Dr. Sharma, Dr. Kinney, could you tell us your preferences on balloons and why each of you seem to have a different preference as to which balloon you use for a BAV?
Yeah, no, basically, actually, you know, there are the two types, the ZMAT and the one is the true balloon. True balloon is a multi-layer balloon which gets to the size, although some people believe that since it does not expand, so they may not do a good job, but I like it. But other one is the ZMAT 2, usually, and we do with the most of the valvuloplasty is 20 millimeter. In this particular case, because of the obvious reasons that we really have to split the kind of commissure or so we are going with a 23 millimeter. The last balloon valvuloplasty was done in this case with a 22 millimeter balloon and lasted almost 1.5 years. And not only that, it made patients slightly better from overall appearance point of view with a 6-point reduction in the BMI.
Where's the pacer?
Okay. Yeah. Okay. So this is the 23 millimeter ZMAT balloon. And the idea there is usually you want to be less aggressive. There are some data to say that don't do the balloon valvuloplasty and you go directly with the TAVR and maybe you cause less stroke, and so there's some data, but at the same time I see that many of those cases you have to post-dilate anyway, and post-dilatation definitely has been correlated or associated with a stroke after TAVR. So we majority of the time we will pre-dilate it, although some people believe that this pre-dilatation manipulation can cause a stroke, but that has not been our experience. Okay, having said that, go with the pacemaker. Yeah, the pacemaker going 180. Sometimes 180 may be too fast, you go to 160, you have better capture.
It's not capturing.
Yeah, it do it. Yeah.
Okay, it's good, good. Go.
Yeah.
Okay, go. See that chunk of calcium did not open.
Good.
Did not open.
That's fine. That we will not more than that.
No, we have to. I think it will.
Okay, go back to the regular pacemaker off.
Yeah.
While they're changing out the valve for the live audience, please email your questions to info@structuralliveheartcases.org.
Yeah. Good. Okay, let's get the valve now.
AR unchanged.
Good. We are 29 millimeter. So there were, based on the perimeter, JK otherwise could have been a 26, right?
No.
What decided basically, what is the, because this one is the where you can go either size, and we learned that you better are on the bigger size than the smaller.
This valve sizing was just in the 29
you want
range.
To go to that view?
It wasn't actually on the border, it was just in the 29 range. So our perimeter we got was 74, and the cutoff is about 72 for going from a 26 to a 29.
Right. Good. But anytime if there is a choice, we always like to go to the bigger size of the valve than the smaller. And I think that is one of the reason that in the partner trial, remember they had a more AI, and so reason is they decided based on the TE. Then everybody learned that CT angio is better TE by definition in the past, not the 3-dimensional 3D, but other TE usually gave 1 millimeter smaller annulus than what came up on the CAT scan.
Yeah, it doesn't go.
Okay, Ani, you come in.
It doesn't go down. Okay.
That's all it stays.
It won't go down.
Yeah.
There's a huge calcium there.
Okay, so keep going the step by step what you're doing. So tell.
So now we have to reorient the pigtail to go to the non-coronary cusp. But I think there's a chunk of calcium. That's all we can get the pigtail at, right?
Yeah.
Now we go cine. Inject.
Looks good.
I think looks okay.
Yeah.
It's going to start releasing now. Our goal is to go lower than usual. Okay, we'll stop here. Yeah, it just moved down. Yeah, okay. Going cine again. Inject. I think so far we are doing good. Okay, this is a key point where he's going to start releasing when it flares. This is the time if there is any movement of the valve. Yeah.
It's okay. Yeah.
Release, release. We're holding good. Did it anchor the other side? Now inject. I think you're looking good. Okay. Start pacing. 160.
120.
Yeah, start going. Release. Yeah.
Hold the wire. You hold the wire.
Keep going, keep going. Yeah, stop here. Okay, Cine again. Okay, inject.
It looks good.
Yeah,
Yeah.
yeah, stop pacing now.
Stop pacing.
Okay, release the valve. I'm going to keep going forward. Still attached, still attached. Still attached. Move it. Still attached, attached. Good, now it got detached. Now let's move the wire a little bit. Let's become coaxial. Come out. Okay, bring it, Mary. It's good. Start coming out. Okay, let's get the pigtail.
Yeah, no, we can take this one out. Let's take this the valve out because it's not going to serve any purpose now.
Okay,
Keep the wire.
wire, wire, wire.
So the valve has not expanded. Will
We
need
know
a
that.
dilatation, and there is a gap with a moderately a moderate amount of paravalvular
Mm.
regurgitation.
Okay. You want to put this one back?
It's okay.
Okay,
It's fixed.
Okay. All right. Put your. Okay. Sorry, the C sheath is the troublesome sheath, but has spurred the blood. What can you do?
I
Anyway.
kept telling them.
Make sure
Earlier also
everybody
the-
gets. Floro, let's go. Yeah.
There's a wide gap.
There is a wide gap.
Yes.
Okay, they should show the echo. Good.
Okay,
They're
ready?
here. Yeah.
Let's do a cine. Wow.
So what do we do now? What size? You want a 25?
6,
we can-
26?
I think we should start slow and be
No, 26 will
Yeah.
be
So-
25. Or we are 25 true balloon.
20, it's 24 true or
So do you want to show the
25.
TEE?
Yeah. Show the TE now, please.
So if
Get
you show the
26 true.
TEE,
No, you need a bigger
you can see that in the short axis
26
view.
true. 26 true balloon.
Can you show the TE? Yes. So in the short axis view, now you can see here there is a lot of paravalvular. It's almost moderately severe paravalvular leakage, and it extends from close to about 9 o'clock position to 2 o'clock position, and the valve is not expanded there.
Yeah.
And we
this,
expected this to happen because of the unicommissural
Yeah?
valve.
26.
Yeah. So well, this is the real time. Now clearly that the valve size, the location point of view, we are okay because knowing that the valve will shrink a little bit.
Not expand.
Yeah. Yeah. This will be good.
So we are going with the 26 true balloon.
Yes. Now, true balloon is this multi-layer balloon of the 6 night knolls and rapid. The biggest advantage of this is rapid inflation and deflation.
So
Just 1 second. Yeah. Okay, Parthu, you want to make any comment?
yes, I just wanted to let the team know that the
Tell them.
valve is not anchored, so you have to be careful when you do the dilatation because it could move.
Just tell them
There's a
it's
wide
wrong
gap, so
balloon.
it is not completely anchored on one side.
Okay. Good. All right. So that, okay, keep saying what's the
Okay,
next
we're
step?
starting with the, where's the pacer?
Pacing.
Yep.
Yeah, start 180.
Start pacing at 180.
Now we
No.
have to make.
About 160.
Okay. No, it's going there.
160.
Okay, good. That's good.
Good.
Okay.
Now we have to make sure
I'm
the blood
going up.
pressure is about 50. Start to go. Good. It expanded. You see it expanded. Yeah. Continue pacing. Continue pacing. This is a very important that they continue pacing and deflate. 1%
And then you take
deflates.
it out.
Balloon comes out. Good. Now you can stop pacing.
Yeah.
Stop pacing.
All right. I can
looks
tell you the
expanded.
valve definitely has expanded.
Yes, so now we'll put the color flow and see again how much is the, yeah, definitely the valve expanded, the AI has gone down. Still there is some residual AI.
think-
I would,
I think you have to live with it.
yeah.
They're coming out.
I would say at least mild to moderate AI is still there.
Moderate to mild minus.
Is it my leg?
I would say it's
let's
moderate.
Ani, what will we do now?
Ani.
I think the main problem is the anatomy with the single commissure and bicuspid valve. So
I think the
I think this
commissioner
is
won't
the
let
best
this.
result we'll get.
Yeah, exactly.
It is very calcified. And also we can get some more expansion as time goes on.
Right.
Pull.
Keep going. Good. Okay. Well, let's go and we try to see our the hemodynamics now. So make sure in one of the side of the screen we show that.
We have a right heart there.
They have it.
Particularly the gradient. PA pressures for how
Your pressures are okay?
Good.
Didn't change.
Yeah.
Well, very good. Actually, there is a good no gradient. We can show the
Can you
hemodynamic
re-zero
tracing.
it? It's 40 EDP.
Is it?
No, it was always no because of
It's a
body
body
weight.
weight.
Yeah.
Okay.
We started that, so no gradient, and the diastolic the diastolic blood pressure minus LVEDP divided by systolic, that the regurgitant index will be more than 25. So that even if there is a little bit, because if you say 70 minus 40, 30, and then divided by your systolic blood pressure about 120, 130. So it will definitely come out about 25. Diastolic pressure still remain about the same. And I think we need to know a little more. Otherwise, we take the pigtail out and do a good ventricular the aortogram.
Okay, ready?
No,
JK?
we are not ready yet. You have to go inside the lumen. Yeah, good. Now.
Okay, can you pull your T probe?
Yes, it's already pulled up.
Okay.
Okay, inject.
Oh, this is allowed.
Yeah.
Alan, what do you think with this AI in this difficult case?
You know, having operated on a fair number of unicuspid valves, I'll tell you that it's a disparate tension between where your conjoined leaflet is, and that's being pushed up to the side. I don't think you'll get a better result with another balloon. I would leave it as it is, and as Ani said, you'll get an enhanced radial expansion over time. So I would leave it and accept this as a successful result.
Yep, and particularly the diastolic pressure is good. The PA pressures remain the same, no change. So many times we do direct based on what has been the PA pressures. If the PA pressure goes up, we are a little more aggressive in reducing that prosthetic regurgitation. And knowing that the PA pressures are good here, our threshold to go after, and particularly in this case, will be less, because I think we have done the good job with the 26. The next choice will be a 28 millimeter, but that will be beyond any of the annular size in this particular case.
And from imaging standpoint, I don't think we need to do that because there's a lot of calcium and it will risk annular rupture. So I think this is a reasonable outcome.
Not
It's actually a
reasonable.
pretty good outcome
Good
for
outcome.
unicuspid.
Excellent outcome. Excellent outcome. Okay, with that note, I think we can quickly go. Will be, of course, the usual process. That is, JK, just go through your process now. How are you going to show the angiogram and how you are going to close this now?
Sure. So we're just going to, there's obviously a great lot of challenge in this lady with her body size. We're very careful in the closure here. Thankfully, the artery that we accessed was nice and clean. We got nice sticks with the perclose. So the first step will be I'll be bringing the contralateral sheath down to the bifurcation, taking some DSA shots, gently withdrawing the large sheath, and then carefully deploying the percloses, suturing them tight and doing some final check angiograms. But we can get started with that now while Dr. Sharma's talking.
Okay, we can go to the slides so that we go another 10 minutes so that we complete the education. Next slide. And this basically we are going to talk about knowing this particular case. Next slide. About the prosthetic regurgitation. Next. And this is basically some people call prosthetic regurgitation, some call aortic regurgitation, some call paravalvular leak, PVL, and it, of course, is a little different. Impact CoreValve versus SAPIEN valve. Next. Now, as you see here, I'll show you the data of the two valves. First, what we learned about the Edward SAPIEN in the partner trial, that even a very small degree of regurgitation, aortic or prosthetic, mild to severe or none to trace, there is a gradient in terms of 2-year mortality. You say, well, how that happened? And I can tell you, to my knowledge, and of course I have the two great colleagues, surgical colleagues here, I'll ask their individual opinion, that why even a mild, we understand once you have moderate to severe or severe, AI means you didn't do a good job. You left a lot of regurgitation, now ventricle instead of AS is getting AI. You have a mortality. But why trace or mild aortic regurgitation should correlate with follow-up mortality as we knew in the Edward SAPIEN valve? So, Alan, you want to comment on it, and then I'll ask Ani on this. That do we have any explanation? Go through next slide, which actually tells you both paravalvular leak as well as overall regurgitation. There is a gradient in terms of follow-up mortality.
You know, we generally don't see any paravalvular leak in open heart surgery, which if we have a little on an echo afterwards, we generally go back on and fix it. In the absence of hemolysis, it really shouldn't have, a trace paravalvular leak shouldn't have much of an impact on loading the ventricle. Having said that, patients with AS generally don't have much AI, so we're changing their pathology a little bit mild. And if the mild is underestimated and the mild is really moderate, well, then we are imposing a little bit of a load on a ventricle that's normally not seen any AI. And I suspect that in the original trials, perhaps they're underestimating the amount of regurgitation there was.
Good. Ani?
I mean, I think the other factor is, I think the AI is a marker for something else. I think it's a marker for the degree of complexity of the pathology on the valve. And for example, heavily calcified valves, bicuspid valves, are more likely to have AI. And it might be that there's a subset of valves that don't do as well with the catheter option, and they're left with AI, and the reason why the patients don't survive well is more to do with the pathology than to do with the procedure. That's what I suspect.
Yeah, and I can tell you that while these data came in NEJM both consistently with the partner trial B and then A, and 1 year and 2 years, this follow-up, when we were doing the CoreValve, we knew that we were leaving mild to moderate not uncommonly, but we are not seeing this correlated. Now, and I'll show you the data of the CoreValve. Exactly that is what we saw. Next slide. And of course, now question comes is, what is the difference in the surgery versus TAVR in these cases next? And basically what they have come up with the prosthetic patient mismatch based on the overall orifice area. Now, clearly that TAVR, because of has a less mismatch compared to AVR, as shown here, insignificant, moderate. This is basically the effective orifice area of more than 0.85, and 0.65 to 85 they call it moderate, and less than 0.865 called severe. And basically, whatever you leave, it kind of remains constant as shown here. Next, and same thing is for this is again in the partner trial, that regurgitation. That while surgery does a great job, despite the mismatch, but great job in terms of very little aortic regurgitation, that TAVR we do see this regurgitation, which do decrease. As you can see, that at follow-up, that particularly your moderate group, orange and so, they do decrease overall from 11, become 6.5 and 6.9 at 2 years. Next. And this is the same, separate depiction of the same. What you leave at time 0, it usually will decrease. Rarely the regurgitation what we leave at time 0 increases, but usually it decreases. Next, or remain constant. Now, little different for the CoreValve. As you can see here, that on the right side, basically we are talking about now with the mild, the blue, the clearly over the time decreases, and this is where we came back with a nitinol frame expanding, that you really decrease the regurgitation at follow-up at 1 year and 2 year consistently in the CoreValve trials. Next. And overall, if you just take the moderate to severe AR, the data have shown you have a higher incidence of moderate to severe AR with the CoreValve compared to Edwards Sapien. So incidence is higher. Prognosis, which I'm going to show, that we saw that Edward valve, there is a gradient. That is it true for the CoreValve also? Next. These are the various predictors, particularly if you're large mean annulus, annular valve size ratio, and that this is the cover index, which is called prosthetic mismatch. They came up with this prosthetic diameter minus TE annulus diameter divided by prosthesis, and it's more than 0.85, 0.65 to 0.85, and less than 0.65. Next. And of course, this is the data from the advanced trial, that in the partner, as you can see, there is a gradient. There is clearly some gradient only after you get to the severe in the CoreValve. Next. And that really, next slide, basically is shown by our CoreValve trial. And this is exactly what we knew when we were doing the trial, that once you have mild, moderate, none, there is no gradient at 1 year mortality. Only when you are severe. Severe basically means you failed. The valve didn't work. So that's a different story. So just to come back to point, while we saw a gradient in terms of mortality with the degree of prosthetic regurgitation, we did not see that gradient in the CoreValve trials, and this has been consistent both in the extreme risk as well as the high risk trial. Next. And now then this is the new kind of tool which is coming up that we call aortic regurgitation index. And what is it? That is your diastolic blood pressure minus your EDP. Like in this particular case, diastolic was 70, your EDP was 20. So now became 50. Then you divide by systolic blood pressure, and systolic blood pressure was 120. So the basically 30 divided by 40 will be about 25, and you multiply by 100. So next slide. That basically means that if your ARI is for good outcome is more than 25. So many times we go through, basically means that you may have a lower pressure, diastolic pressure many times after the valve, but if it's causing increase in your EDP, that's a bad thing. So those cases, next, and they have the whole nice algorithm that what you do with these cases. Mild, of course, you leave it, particularly if it is once you get to the moderate and more than index is less than 20, AR index is less than 25, then you get the help of the angiogram as well as echo, and then really based on the etiology, you take the corrective measure: post dilatation, snaring, or valve in valve. To me, what we have learned, few cases now at handful at our center, which have a 2 to 3 plus prosthetic regurgitation after CoreValve, we pull them up with a really snare, and you really can bring it up because low depth of the valve is associated with more regurgitation. So clearly snaring decreases. So rarely you may have to put a valve in valve, and of course post dilatation like in this particular case we did. But mind it, one thing I always want to say, every study has shown post dilatation of the prosthetic valve is associated with higher stroke rate. We did 162 cases last year. We have 0 stroke at Sinai, although post dilatation was done in about 36% of cases. But we have to be just careful about it, that to try to avoid post dilatation, but sometimes is needed. And of course, whether it is different for CoreValve versus Edward Sapien need to be seen. Next. And these are the new valve in designs which are coming up, which will decrease the regurgitation because of the extra cuff, and you'll hear more and more about it in coming time period. Next. Now therefore, if I sum it up, that the TAVR is associated with higher aortic regurgitation versus surgical valve, likely due to incomplete seal at the annulus by the prosthetic valve, but less prosthesis-patient mismatch. In the TAVR group, CoreValve has higher moderate to severe AI compared to Sapien valve post-procedure. Next. But the long-term outcome of mild to moderate AR or PR post-TAVR has shown adverse prognosis in randomized clinical trial with Sapien valve, but not with the CoreValve, where AR seems to decline over time. So it seems to be maybe this mild moderate does not matter, particularly with the CoreValve, because that continues to expand. With that note, I'll come back to our questions if we have. We always ask them 3 questions about the, continue the slide quickly, and so that yes. The question number 1, following are the true statement regarding CoreValve trials except incidence of moderate to severe AR is lower than Sapien valve. Incidence of moderate to severe AR is higher than Sapien valve. CoreValve trials have shown higher follow-up mortality with the mild AR. Degree of AR increases post-CoreValve TAVR, and severe AR post-CoreValve is associated with higher follow-up mortality. So all are correct except 1. An answer we always give when you go to the website to our audience, and then you'll have the answer there. Question number 2. Optimal aortic regurgitation index is 10, 10 to 15, 15 to 20, 20 to 25, or more than 25. Third, next question. Incidence of AR post-TAVR 1 to 2 year follow-up usually significantly decreases, increases, constant, unpredictable, or mildly decreases. So these questions will be posted, or we'll give it answer next week. But more important, people, we got 2 questions in our some of the participants, they wanted to know the answers for the previous questions. So I have made that. Let's go to the next one now. If we go to the next slide.
14.
Yeah, December 14, yes. This one was that the true statement regarding CoreValve trial, the 1 year mortality is lower than SAVR, CVA incidence is higher than SAVR, vascular complication is higher than SAVR, residual PR is lower with SAVR, and mild to moderate PR after TAVR does not correlate with 1 year mortality. This was our December question. Next. And the second question, they should have answer. Yeah, the answer actually. If you go to next one, sorry, my fault. Keep going. Next, yes. So these are the answer for our clearly that CV incidence is higher than SAVR. That was the wrong answer. Remember, numerically, the first time the CoreValve trial showed the lower stroke rate, although non-significant, but lower stroke rate than SAVR. Second question was regarding SAPIEN and CoreValve trial is extreme risk group, and that is the incidence of 1 year mortality is 20 to 30% with TAVR. So this basically was that we found consistently that TAVR group had a 20 to 30% mortality, as you know, 30% with the Edward SAPIEN in a partner B, and 24% in the extreme risk of the CoreValve. Next. And then lastly is that what is the incidence of degeneration of the valve at 5 years, and the data from the John Webb group in JACC showed that it's about 3.4%. So valves are very durable. With that note, we need a little final comment from Alan and anybody else. How are you doing now? Actually, he has done, yes.
Show you the completion of the access. If you just show the cinaries, please. So there was our final valve shot. If you just show the angiogram, please. So the first step in getting the sheath out safely is we withdraw the sheath. So there's about 3 inches left inside, and this, we take a first DSA shot to make sure there's no perforations, no major problems, dissection, and so on. And you can see there, looking at the left side on the right of your screen, no problems at all, no dissection, no perforation. The sheath is still in, and if we needed to, we could easily run in covered stents or whatever if we had a problem. So the next step was removing the sheath, deploying the per-closed sutures, tightening them up, but leaving the guide wires in so that in case there's a problem, we can re-access. And you can see we've got nice flow down the vessel, nice hemostasis, and the final shot, we remove everything and take our final completion angiogram, and you can see widely patent vessel, from the contralateral side, widely patent vessel, tiny bit of leak out of the per-closed site, but that'll be just dealt with manual pressure. We haven't yet reversed the heparin, so that's what we're doing next, but successful closure with no problems or complications.
Good. I know how you feel now in this high-risk patient with the body habitus, with the excellent vascular closure now.
Can you give pro to me?
Right?
Yeah.
I mean, that was our biggest concern in this particular case.
Yeah, I think now we have to make sure your other right side is also okay. Most of the time, people pay all attention to the main area, and any complication or hematoma can happen from the smaller access site also. But knowing the body habitus, when we actually saw her first, we were always concerned with the percutaneous access, but looks like JK did an excellent job.
Ani, last comment from you, and then Alan will close it.
I think obviously the post-operative phase remains, challenging for her. She was intubated for this procedure. Her BMI is 44, borderline lung function. Hopefully she should get extubated in the next few hours, and the goal will be to mobilize her as quickly as we can. She will have a temporary pacer for a couple of days, which might limit her a bit, but in an obese patient, really, we want early mobilization for her.
Okay, Alan.
I think this is an excellent example as we've moved away from inoperable patients, and then as a collaborative effort decided that these are cases that are reviewed by our surgeons, Ani and myself, reviewed by Dr. Sharma and Dr. Kinney, and we decided this is what I think is best for a heavy patient like this. We could operate on this lady and get her through the operation, but she's not going to progress all that well. She's at a high risk for a sternal wound complication, high risk of respiratory failure, pulmonary embolus, so it's not something as a surgeon we're thrilled to operate on, and I think this is a great example of a patient that we review together and we find is best served by a TAVR, and look, she's had at least an excellent procedural result, and now we'll focus on excellent post-operative or post-care management, get her out of the hospital, mobilize quickly, and I think she'll really progress well, and it shows the advantage of this new emerging technology. Thank you.
All right, thank everyone.
It's important to know that our next CCC live case will be next Tuesday at February 17th. And again, all questions can be emailed to info@structuralheartlivecases.org. Thank you.